and working within the NHS, that's my expertise can help develop this part of the process. And what I promised Dr. Adnan, if these sessions go well, I will find colleagues, and with Ijaz Bai's help as well, we will look for colleagues who will be able to speak more on this part of the process, the first part, which is what I was initially asked to do. Okay, so I just wanted to set the scene here. I don't have the expertise to talk about the routes of entry into the UK as an international medical graduate, but once you land in the UK and you're thinking about doing the PLAB exam and registering with the General Medical Council so that your Pakistani qualification is recognized by the GMC, that's where I come in as your a person to be able to support, guide, and give advice. And why is that? Let me tell you a little bit about me. So what are my credentials? So I'm a consultant ophthalmologist. I've worked in the NHS now, including my registrar training, for 22 years. I've been a consultant for 19 years, okay? And last year, I left the UK and moved to the USA. And that was because my husband got a job in the USA. So we all decided to move as a family. In my 19 years as a consultant in the NHS in medical retina and ophthalmology, I was heavily involved in medical education. So I was college tutor for the Royal College of Ophthalmologists. Then I became examiner for the Royal College of Ophthalmologists. And I examined for Part 2 FRC Opt and for the refraction certificate. I also became a CSER assessor. So I assess CSER applications. I'm going to explain that to those of you who don't know what a CSER is. And I also work for the GMC on the tests of competence and revalidation panel. And throughout my 19 years as a consultant, I was a trained appraiser. So I used to do appraisals for my consultant colleagues. And the final role that I have is I am a coach for the NHS Leadership Academy. So I support junior doctors in the NHS who are struggling or not struggling, even those who are doing very well, but want to achieve more without sacrificing their health and their family. So that's my background, okay? And that's why I was very excited to deliver this talk for you today. Can I have the next slide? So without further ado, let's get straight into the content. What about applications and interviews for the ophthalmology job? What common feelings are associated with this process? The things that I thought of, and I'd be very interested to hear if the chat is working, please feel free to type into the chat. What feelings do you associate with the application and the interview process for any job that you may have had to date in your experience? Feelings of uncertainty, anxiety, stress, a lack of clarity regarding expectations, especially for the UK interview setting? Are you ever wondering, will my experience be the same as a UK applicant who's going for the same job? Do you worry that you don't have enough publications or research on your CV? Because I commonly hear that from junior doctors. And finally, a real strong sense of I don't need to change my personality or my values in order to fit in with a different culture. And I think that comes through very strongly in some of the coaching sessions that I've had with international medical graduates. And I completely agree. Nobody should need to change their own values and their own personality in order to fit in, because that's not authentic and that's not comfortable. But we're going to talk about that a little bit more. Can we have the next slide, please? So I wanted to ask, is the chat working, first of all? Can people type into the chat? Is it working?
Yes, ma'am, I think it's working.
Okay, let's see. I'd be so grateful if the audience would type into the chat. What tips do you think this slide is trying to tell you for your first step when arriving for an interview, attending an interview for a job? Tell me, what is this slide trying to, what do you think the clock means? What do you think this picture means? What do you think this picture means? I'd like to see what sort of things are coming into your mind. Anybody? So I'm going to start calling out names if nobody's going to type in. So Dr. Aslam Memon, my brother's name is Aslam, so that's a really lovely name. Aslam, would you like to type into the chat, what do you think I am trying to message, I'm trying to give by putting a clock here for preparation for interview? You can either speak or type into the chat. So maybe it's not working because I'm not getting any response. Anybody else?
Hi, I think it means plan and prepare timely and plan well.
Thank you, Ibrahim. That's right. There's also an additional thing. If your interview is at 4 o'clock, you need to get there. You need to be there in the place by 20 to 4. You must be there early because you need to give yourself time to find the room and just arrive and settle and feel calm. So what you said, exactly right. Give yourself time to prepare, but attend earlier than the actual time of the interview. And then for this picture, dress, obviously, how you appear for the interview is very important in smart professional dress. And then eye contact. When you're speaking to your interviewer, those non-verbal cues are so important. You're looking with gentleness in your eyes when you're answering the questions, but you're also a pleasant, open demeanor. So say they ask you a question and you're not sure of the answer, you may feel nervous because you're thinking, oh, I don't know this, I didn't prepare. But what is your body language saying? If you close up and you look down and you frown because you're thinking about the question, remember they're looking at you and they're asking themselves, is this a future colleague that I would like to work with? Is this somebody that's going to get on well with the other members of the team? So in the interview, that is your opportunity to show a little bit of your personality as well and your gentle confidence, not overconfidence, but the appropriate amount. And that's by having eye contact when it's appropriate, but not always looking down. And these non-verbal cues are very important as well. And so I just wanted to raise awareness of that. Can we have the next slide, please? When you are preparing for your ophthalmology interview and you are putting in an application, you will be asked to fill in a detailed application form. Never, ever do a handwritten one. Always type it. I have been present in shortlisting where if it's handwritten, it goes straight in the bin. Because why? Not because they're trying to discriminate against somebody who doesn't have a computer. It's because they feel like the effort needs to be made to present the form in the most professional, most tidy way. And in this day and age, that has to be electronic. So that's the first point. The second point about the application form is you will be asked questions about clinical governance and showing your understanding of clinical governance in the NHS. If you're not familiar with this term and you want to come and work in the UK, it's very important that you understand and Google this, clinical governance. There are 7 pillars. It's your evidence of how you incorporate this into your medical service. So how do you assess risk, clinical safety of the patient? How honest and open are you with the patient if something doesn't go to plan? And we call that the duty of candor. And that's really important. And it will come up in an interview situation. And they could ask you questions about, give us an example of your biggest mistake that you made professionally. And what did you learn from it? So research and development, how were you involved? What did you achieve? What were your outcomes? What is your understanding of ethics with regard to research and patient confidentiality? Clinical effectiveness, looking at ways to improve quality of your medical service. And clinical audit is a way of assessing whether you are doing what you are supposed to be doing? Is your service delivering the standard of care that is required based on guidelines, official guidelines from the Royal College of Ophthalmologists or the General Medical Council, or whichever regulatory body you are working with, the equivalent in Pakistan, for example? So that's the point there. Always type the form. Always understand that they will be predictable questions, and start to think about examples of how you can demonstrate that you actively incorporate clinical governance in your medical service. You can do that from now by starting to think about it, and always fill in all of the questions with the most detail. And we're gonna talk about that a little bit more in the next slide. If we could have the next slide, please. Thank you, Dr. Adnan. So prepare for examples for predictable questions. Predictable questions, teamwork, multi-professional working in the UK, in ophthalmology, eye care teams, clinicians of all grades, nurse specialists, orthoptists, the optometrists, the healthcare assistants. We work together as a multi-professional team. And it's very important that this is a concept that you understand, because it's very likely that they will ask you about it in interview. What they're looking to see is, are you as an international medical graduate, even if you've never worked in the NHS, have you started to try and find out how the NHS works as an organization? So if you were not in medicine and you were applying for a job in a company, for example, you would find out about how that company works and what their important values are. What are the values of the NHS? And so that is important, and they will ask you questions around that. So teamworking and inclusivity and multi-professional working is what this picture, the first picture, is about. How do you give and receive feedback? That's another really important thing. Getting multi-source feedback every 3 years is part of the appraisal process and is important for revalidation. Multi-source feedback means asking at least 12 colleagues of different roles. So not just your senior consultant ophthalmologist, but nurse practitioners that you work with, the theatre team that you work with, asking a range of people to give feedback on what it's like to work with you as an individual. So how do you then use that feedback, and what examples can you give of listening to feedback and using it to change your practice? That's a very predictable interview question, but it's also something to reflect on, because we all, as human beings, need to take feedback in a way to use it to improve ourselves. And this is something that we all do to varying degrees of success. I'm sure you'll agree. Some people are very good and some people are not so good. So that's a whole session in itself. What about your poster presentations? What projects have you been involved with? This third picture on the right is to remind you that in your interview is an opportunity for you to talk about your achievements. They want to hear what you're proud of. What did you do that made a difference to your patients? What did you do that made your colleagues happy with you, that showed that you were a good team player? And then once you've made a list of all the predictable questions and you've tried to think about examples from your real world experience and you've written them down to prepare, then you need to verbally say it as a good preparation technique before you go to your interview. Even if you're looking in the mirror, as a matter of fact, that's the best way to start. Look in the mirror and say, give me an example of a time when you showed good team working skills. And then say what you want to say. Don't learn it by rote, because that sounds mechanical and that's not a good look in the interview. But have the main points in your mind, have the story in your mind so you can describe it in a natural, authentic way. Okay, so that's the point I wanted to make here. I hope that that was useful. Can we have the next slide, please? In summary, the main points I've made so far: arrive early to your interview, dress smartly, have good eye contact, and remember, non-verbal communication, it means a lot. They're watching and you're there to do the best you can and to answer questions, and you will naturally feel nervous. They are looking at you and they're trying to picture, are you going to fit with their team? Are you going to be a person who's going to be easy to talk to discuss cases with? Are you going to be reliable? Are you going to respect start times and finish times? You know, are you going to have good time management skills? What about your personal organization? So that's what they're getting, all of this information just by looking at you in the interview room. What the form, make sure you type the form, don't handwrite it. Prepare examples for predictable questions such as teamwork, evidence of participation in clinical governance, multi-professional working, time management, clinical risk, audit versus research, know the differences, have examples of your personal participation ready. The colleague, oh, this is a very common interview question, and this might be a little bit shocking because of the difference in culture. So the colleague who arrives to work unsafe to practice if they are inebriated, for example. I've never seen this happen in real life, but they ask it in every interview, or it's a very common interview question. So you need to know the answer. The colleague who arrives to work unsafe to practice, how do you deal with that? Because remember, patient safety is your #1 concern. And if you let a colleague go ahead and do an operation when they are clearly not in the right state to do so, that is something that you just can't allow to happen on your watch. But you have to know how to respond to that situation in the appropriate way. And that would mean escalating it to a senior colleague as soon as possible, but trying to speak to the colleague first to see if you can get them to put down the, don't proceed with patient care when you're not in the right state to do so. What is your biggest mistake that you ever made, and what did you learn from it? What about leadership styles? What examples do you have of ever showing leadership? Duty of candor is very important. Many of my colleagues who've had interviews were asked about, what is the duty of candor? Can you give us an example of when you demonstrated this? So I can give you an example of when I demonstrated this. In maybe it was about 6 years ago, I was delivering a PDT, half fluent PDT, to a patient who had chronic CSR. And the PDT machine stopped working in the middle of the treatment. So I stopped and I explained to the patient, I am so sorry. You see, the patient doesn't know, right? The patient does not know. You're just pressing a button and the pulse is being delivered. You're holding the lens. They've had the Visudyne. So the patient doesn't know. The whole point about duty of candor is being open, transparent, and honest with the patient about anything that doesn't go to plan. And that's showing the patient respect and dignity. And so I explained to the patient, this treatment has not been completed. We need to reschedule you for another treatment. I am apologetic on behalf of the hospital because the equipment was not correct. Perhaps the maintenance was an issue. But me as a consultant, I learned from that case that I need to check, has the machine been maintained? Has it been checked? When was the last time, it was used? And is somebody looking after this? Like, I need to ask these questions if I'm going to use it to deliver treatment for a patient. So that was both my biggest mistake and example of duty of candor. And then things like what's going on in the NHS. Remember I said, if you're applying for a job to any company in the world, let's just pretend you're not a doctor for a minute. You need to find out what that company stands for and what's important to them and what's in their 5-year plan. Now, the NHS wants to go digital and wants to use electronic patient records completely. by a certain target in the future. What are the pros and cons of this? So remember to practice saying your answers out loud in the mirror or recording your answers. Some of us have a habit, highly intelligent people can be speaking and often say things like, you know, they just do that out of nervousness, but that can make you sound very unpolished and unintelligent. So listen to yourself. How do you sound when you speak? Are you talking clearly? Is the other person understanding you? Or is your speech too fast? Is your tone too aggressive? What about your pace? You know, if you have, you have to check, has the other person understood what you've said? So when you record yourself speaking your answers, you will be able to pick these things up. Okay, can we have the next slide? This next bit is very interesting, okay? Important points that you must not do when you are going for an interview. Never ever list your qualities. For example, saying, if they say, okay, tell us about your strengths. Well, I'm a very hard worker. I'm very good at working in teams. I'm very knowledgeable, and I'm a very good cataract surgeon. You can't say that because you need to provide personal examples and evidence, okay? Please don't misunderstand me. It's important to be proud of your achievements. If you are very knowledgeable and you are very good at making diagnoses, like the diagnostic dilemma, for example, and you pick out on small points in the history and the examination, and you're very knowledgeable and experienced in that sense, that is something to be proud of, and definitely that is something to share, and we must do that because we're all very shy of not appearing to show off if we have skills or strengths. What I'm trying to say here is don't state it, show evidence for it. So give evidence of your qualities in your answer. So instead of saying, I work very hard, say, I'm often the first to arrive and I'm often the last to leave. So then the person who's interviewing you understands so much more than saying, I work very hard. If you are saying, I am a good team player, what you could say instead is the last 360 feedback I did, or the last multi-source feedback project I did, when I asked my colleagues, what am I like to work with? They all said that they enjoyed working with me and that I was a good team player. So multi-source feedback says, i.e. you have evidence for that statement and you are sharing that. The third thing, I'm very knowledgeable. Instead of saying that, you can say, I made a diagnosis in a patient with subtle clinical history and signs, and my clinical supervisor was very impressed. For example, my complication rate for posterior capsule rupture in cataract surgery is 0.25%. This is significantly lower compared to colleagues at my stage of training based on our department audit results. So do you see the point I'm trying to make? Always provide evidence, but you need to find the evidence first so that your interview answers are supported with evidence. So you need to take some time to find out what your cataract surgery complication rate is, for example. Okay, next slide, please. There's one other thing that you must never do in an interview, and that is ramble. Ramble means there's no beginning, middle, or end. They're saying, okay, tell us about a time when you showed good organization, good personal organization skills. And then you start saying, oh yeah, well, once there was this event in my department and it was a conference and one of the consultants was retiring and I was asked to organize and I organized a list of speakers. Already, right? Everybody's bored. You have to say your answer with a structure. What was the situation? What task was your responsibility? What action specifically did you take? And what were your results? So that is the STAR format, STAR. And you should have a little example for everything we've talked about: teamwork, communication, biggest mistake, biggest learning, what you learned from feedback, quality improvement, research, audit, teaching. You need one example in this STAR structure. So in an interview, then even if you get stuck and they ask you something and you're like, oh, what are they asking me about? At least you've got something ready. You can say, oh, you mentioned teamwork. There was a time when I did this and that showed that my colleague said that, you know, so you're prepared and you're ready. Can we have the next slide? Now, we talked about what you shouldn't do. Let's talk about what you should really try to do with your interview answers. Demonstrate the principles of good medical practice from the GMC, okay? Those principles are four. Care of the patient comes first, and keeping up to date is part of that. So knowledge, skills, and procedures is all about caring for your patient. So making sure you have the right knowledge, the right skills, and that you're able to do the procedures that you need to do. This is all part of your continuous professional development, and it ties into your appraisal process. Number two, prompt action needs to be taken if patient safety is ever compromised. So this is part of the safety and quality domain, which links into appraisal. Number three, working in partnership with patients and colleagues, partnership and teamwork, domain 3 of appraisal. And finally, maintaining trust. As professionals regulated by the GMC, we are held to a higher standard as doctors caring for our patients. We need to think about probity, that's professionalism, and doing the right thing in the right situation at the right time for the right reason, okay? You can't just walk away if somebody's in trouble and you have the skills to help them and you walk away. That is not probity. And duty of candor, I've already explained to you. That's very important with regard to maintaining trust. Can we have the next slide, please? The other thing to try and bring into your interview answers are an understanding of the 4 pillars of medical ethics. Understanding patient autonomy is so important. Respect for patients and their right to self-determination. If they're of sound mind and they refuse treatment, we as doctors respect their decision because of autonomy. The patient also has autonomy. Beneficence, the duty to do good, which I just explained. Non-malfeasance, the duty not to do bad. And justice, to treat all people equally and equitably. Can we have the next slide, please? So, resources to help you prepare. I talked about research and the fact that for people preparing for applications for jobs and interviews, one of the most common things I hear is an anxiety with regard to the research section of their CV. Oh my gosh, I don't have enough publications. I need to have more, posters and papers. And, that's very common. But what can you do? What can you do now to start building your portfolio? If you haven't done very much audit, research, project work, start at step 1 by getting your good clinical practice training. In the NHS, any doctor who is collaborating in a research project needs to have a certificate. And that certificate is called the GCP certificate. And you can go online and you can do this free of charge and get your certificate and keep that up to date. And that's the beginning of your portfolio for research. That's step 1. Then step 2, find some like-minded colleagues and think of a project. Look through an ophthalmology journal. See what is topical in your field of interest. See what letters are being written. Write a letter. That's a good first start. Let me share a story with you. I was off sick. This is about, 15 years ago. And it was Ramadan. And I was home and I was sick. And I was reading a journal article about patients missing their eye drops because they were fasting and that this was exacerbating their glaucoma. And I was really moved by what I read. So I wrote a letter just there and then. I wrote a letter. I sent it to the BJO or wherever it was, and it got published. So that was a really fruitful day off sick for me. So you can do the same if you just read first and see what inspires you and see what you feel compelled to write a reply to. That's your first stage in building that section of your CV. The next thing, basics of clinical audit. I just found this resource online, and I'm happy for Adnan to share these slides with everybody who's attending, so feel free to take these links. This was actually from a veterinary website, but it was a really good introduction to clinical audit for those of you who are very junior and who want to start with good habits. And then if you're coming to the UK, you need to know about NICE, the National Institute for Clinical Excellence. This is an organization that basically determine which treatments we can use in the NHS, and they evaluate the cost effectiveness. There are 76 ophthalmology topics that NICE have commented on. So you need to know these. Excuse me. And then finally, make sure you go to the Royal College of Ophthalmology website and look at the standards and the guidance documents and have a read of those. It's very good for your personal experience and your own clinical management in ophthalmology, but also it will be very useful for anything you do from that point on. So if we go next slide, please. At the beginning, I talked about common feelings associated with the application and the interview process. So that feeling of uncertainty, my invitation to those of you listening is replace that with preparation for your interview. And recall past interviews that you've done successfully. You can do this. You just need to remember what steps you took to be successful last time and make sure that you repeat those. I'm going to let you read this slide for 1 minute while I clear my throat. Okay, for point number 2, lack of clarity regarding expectations in the UK interview setting. So we've talked about how you can plan for those predictable questions and have examples, but don't try and learn a script. That will not be a good look. But do have some ideas of what you would say if you were asked about patient confidentiality, for example, and many other examples I've already shared with you. And that's the same point for point number 3. And for point number 4, I've already covered. And finally, for point number 5, I do not need to change my personality to fit in with a different culture. No, you do not. Absolutely correct. You are your own person and you have your own values. And equality and diversity and inclusion is all about each of us respecting each other as we are. But do be aware that to build trust, there are 3 components. Empathy, so putting yourself in the other person's shoes. Also, authenticity, being your real self and not trying to like have a mask, because people can feel it, they can sense it. You might be having that mask or a professional persona as a protective measure, or even you might be of that, you might feel more comfortable to have a professional demeanor and a different one for your own friends and family. And that's fine, but just be aware that, you know, your true self, people can feel that when they experience it from you, and it builds trust. Whereas if you have a barrier, then that stops trust from being established. And that can be what is the underlying cause of problems with developing relationships and good working relationships. That's just something to point out. And then logic builds trust. So when you are demonstrating that you work in a logical sequence, that you're using the same guidelines and the same standards that everybody else is in the NHS, and you're not doing different management plans, that will build trust. Being pleasant, approachable, but also remember your own micro behaviors. If, for example, we're all human and we're all sensitive. If I walk past you in the corridor and I'm thinking about something else, I might not say good morning to you. I might not say salam to you. I might just walk past you. And then what will you feel? You'll feel, oh, Rehna Khan just walked past me and she didn't even say hello. That wasn't very kind. That was a little bit rude. And you'll feel sad inside, right? This is what we call micro behaviors. Sometimes you don't know that I might have just received some bad news and my mind might have been somewhere else, but you know, it's how we perceive each other. Equally, even if I've got something on my mind, if you walk past me, I can say to you, oh, Assalamu alaikum, it's nice to see you. And those two words will make such a better day for both me and for you. So this is what micro behaviors are about. And I'm going to talk more about this in our next session. Okay, can we have the next slide, please? Because this was part one of today's, which I've spoken about a lot. And then part two is how do you make the best of your job? Now, Ibrahim Khan is with us from Birmingham, and it's his first few days in his new job. So this next bit would really relate to people in Ibrahim's situation who've just started their new job. So if you're new, what are the common issues? People tend to go into it. This is what I see from my coaching and in my experience. People tend to arrive, my colleagues come to work and let's see, is today going to be a good day or a bad day? You know, let's just go with the flow. They leave it to chance and they have this voice inside often that's telling them, oh, you're not good enough, or oh no, look what they're doing something else, you know, that's what you should be doing, or you're not doing that, and oh, they don't like you because they didn't say hello to you this morning. That disempowering negative mind chatter, we all have it. And limiting beliefs, we all have them. Also, this feeling of, well, I'm not a ST trainee, I'm a trust doctor, so I don't have protected teaching time. I feel like an outsider here. There's definitely racism, you know, in these countries. There's no, and then also I notice that one of the common issues are people will come to work and there are things going on at home in their personal life or their own choices about their own lifestyle, going to bed late at night and then feeling really tired and grumpy in the morning, for example. People are not setting boundaries to enable themselves to succeed. It's like set yourself up to win, don't set yourself up to fail. So these are the common issues, okay? So let's talk through them very quickly because we're aiming to finish now in the next 10 minutes, if that's okay. So can we have the next slide, please? So how can we, what are the solutions? Instead of going to work and leaving it to chance, let's see what happens today. It might be a good day, it might be a bad day. No, have a little bit more planning and a little bit more purpose and visualize what you want to achieve each day. So set a goal. At least every day you go to work, you should achieve at least one piece of evidence to go into your portfolio. Think about what time you go to sleep. Think about what you're eating, because that's going to be giving you energy or taking energy away from you if you're not eating healthy foods. What about your childcare situation? Is that weighing heavily on your mind? Is it, are you, oh, I need to leave at 4 o'clock, otherwise my child's not going to be picked up, and that's causing stress, and then it's causing conflict. And these routines are very important to identify what is impacting your success. And then taking time out to think, what can I change so that I can set myself up to succeed? Make clear goals. And you know that little voice in your mind that I talked about that can also be very mean sometimes. It can be a very harsh voice. Oh, Rehna, you're not good enough. Rehna, you didn't do enough research. Or Rehna, you haven't done enough projects. We all have this mind, negative thoughts. What you need to do is become your own best friend, and change that voice when you catch it being harsh. Say, now, come on, let's be kind to let me be kind to myself. Just like when your friend is feeling down, what words do you say to encourage them? Say those words to yourself too. It's very powerful. I'm going to add value to my day. So be aware of those micro behaviors that I touched upon. We can't change others. but what is within our own gift to change in order to make our day valuable. Can we have the next slide? Now, a little bit more objective, okay? Let's talk about the difference between portfolio and CV, connect to the curriculum and the personal development plan. So if we can have the next slide, please. Thank you, Dr. Adnan. Now then, the portfolio versus the CV. Now, your portfolio is like, if you take the analogy of a research paper and then you look at the abstract, okay? The research paper has the full details of the introduction, the method, the results, and the conclusion in full detail. The abstract just gives you like the snapshot. Your portfolio is the full paper and your CV is the abstract. It's also the same as the full book versus just looking at the chapters. Yes, when you look at the full, you have a book and you have all of these pages, that's your portfolio. But just the front, the chapters in the front of the book is basically the headings, what they're going to talk about. That is your CV. So the portfolio needs to contain detailed evidence of what you've achieved and evidence that you have maintained those competencies, okay? Each learning outcome is a competency, and that is matched to the Royal College of Ophthalmology curriculum, which if you just put into Google, Royal College of Ophthalmology curriculum, it will come up as a grid. There are 180 learning outcomes for every ophthalmologist. They're required to achieve them at different stages, but if you're already at a senior level, it's about maintaining those competencies and showing evidence for that. And what they want to see when, for example, if we're doing an assessment to see if a 5-year or 6-year period of training is equivalent to a specialty training for ophthalmology that leads to consultant grade in the UK, that is certificate of equivalence of specialty training. People submit their portfolio of evidence and it is assessed by the Royal College of Ophthalmologists. And if it's found to be equivalent, they will be awarded this certificate of equivalency and then they can become a consultant. So how that triangulation of evidence is very important in that process. And therefore, I would invite you to do the same as your normal evidence collecting exercise. What do I mean by triangulation? One piece of evidence is not enough to say that this doctor has achieved and maintained the competency of corneal gluing, for example, or management of dry eye. One piece of evidence isn't enough. I'm sure you would accept that. So it needs to be triangulated. So having the fellowship exam is one piece of the triangle because that will assess many of those learning outcomes. Then having some workplace-based assessment where a senior colleague has directly observed you doing this and they can attest in writing that this doctor can effectively manage diabetic retinopathy. I have seen them do X, Y, and Z. This doctor has discussed a case of diabetic retinopathy with me, and I am able to certify that they have these competencies, X, Y, and Z. So that's what workplace-based assessment is. And then your own clinical letters, multi-source feedback. So another piece of evidence. So that's how you form the triangle. The exam is one corner. Your workplace-based assessments where you've been directly observed showing that competency. And then the third point of the triangle is another piece of evidence. For example, clinic letters, multi-source feedback, PowerPoint slides if it's a teaching. Different competencies will have different evidences. The CV is a summary list of your achievements with specific headings. It doesn't have any evidence. So hopefully now you are all clear on the difference between a portfolio and a CV. And if we can have the next slide, please. I want to make a mention of LinkedIn because in today's day and age, every professional person, and especially if you're going for an interview, your interview So they'll start to get develop a picture about you and your competencies and your knowledge and your experience even before they meet you, even before they've read your application form, because they'll look on LinkedIn. So LinkedIn enables you to tell employers the story of your professional life on your terms without the limitation of a standard CV format or a small amount of room. It's important to think about your LinkedIn profile. Choose a photo that looks like you, ensuring that your face takes up at least 60% of the frame. And in that picture, have a nice, pleasant picture with you smiling with your eyes, ensuring that you appear warm and friendly, and wear what you would wear to work. And choose background that is not distracting. And a little note here on doctors' use of social media. This was an important story that came to my attention. So as you know, I worked in the UK, now I work in the USA. And social media profile is, you know, something that everybody checks, whether it's an interviewer, a future employer, the immigration people at the airport. So the point I want to make is I am originally from Peshawar in KPK. And at a family wedding, my family, you know, when they have a tradition and they shoot guns, right? And they said to me, oh, you want to shoot a gun? And I said, no. I said, if I am seen with a gun in my hand shooting and that goes on social media, that will ruin my image completely. Then what will my patients feel? Like, it's a different culture. It's just not appropriate. So I hope that that was okay for me to share that story, but I just wanted to give you a different perspective. Yeah, and just always think about, once it goes on the internet, it can never come off. So be careful what goes on there and what image it gives of your professionalism. Can we have the next slide, please? So I really want to make this point about the curriculum. I invite all of you juniors who are looking to build up your portfolio, please look at the Royal College of Ophthalmology curriculum, 180 learning outcomes. Different workplace-based assessments are designed for different skills, knowledge, and procedure. For example, an OSAT is an objective structured assessment. Oh gosh, I forgot what it stands for now. What's the T? I can't remember. DOPS is a directly observed procedure, and a CBD is a case-based discussion. So there's lots of letters. Don't let that confuse you, okay? They're just different types of assessment in the workplace, and you can download those forms if you like. If you have a goal to come and work in the UK, why don't you start now while you are in Pakistan? Download the forms and ask your seniors to just fill them in. They're very self-explanatory. For example, if you are removing a corneal foreign body, there is a DOPS for that, and just ask your senior to fill it in, and all they have to do is sign it and stamp it, and that can be the beginning of your portfolio. Examples of learning outcomes: patient investigation, patient management. This is how the curriculum is divided up into different types of learning outcome. Surgical skills, practical skills, clinical assessment, and there's a few more. This list is not exhaustive, but I just wanted to explain it to you. PM15 is patient management of contact lenses. 9, perform a lateral canthotomy and cantholysis. PS is practical skill 12, punctal occlusion. Are you aware of the different methods of punctal occlusion? Punctal plugs, cautery, surgery. PI12 is patient investigation, biometry. Are you able to do a biometry for a patient who's going to have cataract surgery? Can you enter the results of the biometry? So case-based discussion, for example, go in and discuss a case with your senior, document what the discussion was, what were the learning points, what was interesting about the case, what will you do next time? So it's all documents of reflection and putting them into your portfolio. HPDP, remember, that's a different type. It's health promotion and disease prevention. This is related to screening and vaccination. Promote the value and assist in organized screening for eye disease, diabetic eye disease. Now, I know in Pakistan, you don't have a national diabetic screening program, but there's lots of little projects locally going on, I believe, for diabetic screening, or maybe there is a national screening program now, and I just am not up to date. I'd be very interested to hear. But in the UK, there is a national screening program, and all ophthalmology trainees and doctors are required to know and contribute in promoting disease prevention. Can we have the next slide, please? Right, I'm running out of time, so I'm going to race through the next few slides, okay? Personal development plan. Now, once you've got your job, you need to decide, do you need to do a personal development plan for every 3 months, every 6 months, or every 12 months? As a consultant, we do one for every 12 months, and that is a big part of the appraisal process, annual appraisal. So when you're training, you might wish to do, if you've got 6 months in ocular, you have to do mandatory training every year. For example, aseptic technique. And so that could be additional evidence for this learning outcome as well. And people can say in aseptic technique, they wash their hands thoroughly. When their gloves got torn, they stopped the procedure and they went and they changed their gloves. They didn't just continue. Like these kind of examples that somebody writes to show evidence. Can we have the next slide, please? Thank you. Another example, you could say to yourself, I'm going to complete an audit within 12 months. And, you know, completing an audit isn't enough. You need to show that you've completed the audit cycle so that you've done the loop the second time. So you ask yourself a question, am I achieving the correct outcome in procedure X? And then you do the audit and then you have an answer, either, yes, I am achieving. That's great. Make sure you continue doing what you're doing so that you're showing evidence that you're maintaining that excellent result. So that's your second audit, and that means you've closed the loop. Or you could show that, no, I'm not achieving it. And then what steps do I take to change my practice so that I do achieve it, and then re-audit to show the impact of those changes? That's what we mean by closing the loop or completing an audit cycle. And that is essential for revalidation. Every doctor registered with the GMC with an active license to practice needs to revalidate every 3 years. I think every 3 years or every 5 years, but they have to, doing an annual appraisal is part of that revalidation process. The other thing you could put in your PDP, for example, is I must attend a conference. When you attend a conference in ophthalmology, write your reflections, show your attendance, save your attendance certificate, put that in your portfolio. If you've actively contributed, for example, you've asked a question, make a note, because this is all evidence that you actively participated. Conference itinerary doesn't give any evidence of your learning or your change of practice or your continuous professional development. So that's why you need to write these things down. Can we have the next slide, please? Headings for a good CV. Hopefully you all know this. I'm sure each and every one of you already have a CV. Executive summary is the first thing, because the person who's looking at your CV just wants to get a picture of who you are, what you do, what you've done, and what you want to do in the future. Education and quality, job history, your clinical experience, any prizes and awards that you've received, any teaching that you have participated in, and when you're more junior, teaching that you've attended, I guess, is relevant. Audit projects, publications, memberships, for example, international member of the American Academy of Ophthalmology, and so on, which you could sign up for. I don't think it's even a significant charge, especially if you're in training. Who are your referees? Their name and their address and their email. So these are headings for a good CV. Can we have the next slide, please? We've talked about the personal development plan, and finally, because it's all linked, can we have the next slide? Make sure any PDP objective that you put down is a SMART objective. Hopefully, many of you will be familiar with this acronym, SMART. It means it's specific, it's measurable, it's achievable. It's so that your PDP starts with a narrative of your progress on last year's do an ARCP instead of an appraisal. Okay, but for most of you who come to the UK, you will most likely be involved in the appraisal process. So it's very important that you have some idea of what that is about. And it's about providing evidence in these 4 domains. So knowledge, skills, and procedures. So you've got to show examples of learning, case-based discussions. That's how you would show evidence. Safety and quality, that you're involved in audit and clinical improvement. And one example of this, I can tell you, my very good friend, Professor Rachel Pilling, she won an award for a quality improvement project that she did that would have come under domain 2, but that we can all benefit from, which is why she won the award. And it's called 50S30M. Okay, 50S30M, Rachel Pilling. I think if you Google that, it will come up. And it's about how you spend 50 seconds now to save another colleague 30 minutes later. And that's a quality improvement project that they did. So domain 3, communication, partnership, and teamwork, and domain 4, maintaining trust. So showing evidence in each of these areas. They will ask you to fill in a form, and then they will ask you to, for domain 1, they will want to see your CPD diary. You should have at least 50 points every year. Safety and quality, they want to see at least participation, at least 1 audit project. Communication, partnership, and teamwork, they want to see feedback from patients, thank you cards, feedback from colleagues. You have to do a formal one, which is quite involved, where you have to ask about 20 patients and about 13 colleagues once every 3 years. But the informal evidence of communication, partnership, and teamwork from emails and letters and thank you cards, you need to build this, show this evidence. And maintaining trust. They'll ask you, you know, if there's any issues, any complaints, what you learned, that kind of thing. So can we have the next slide? Thank you. I was going to ask what you already knew, but in the interest of time, I'm just going to tell you the 5 main things. If we can have the next slide, and I think that will be the last one, and then I'll be very happy to take any questions. So 5 things you need to know about appraisal and revalidation. It is a developmental process. It is not a pass-fail process. It records issues arising, for example, patient complaints that you've had in the last 12 months, but it records it in a way that supports the personal development of the doctor. Do you remember right at the beginning, I talked about giving and receiving feedback? It's so important for all of us as human beings to improve. And essentially, appraisal is like a structured process to find, okay, this is what's happened. How can we learn from this? What can I do differently, etc. Non-engagement in appraisal can result in the loss of a doctor's license to practice. It's a very serious business. I hear lots of colleagues say, appraisal's such a waste of time. I wish we didn't have to do it. But you know what? Don't waste your time complaining about it. Just do it, and do it to a good standard so that it helps you build your portfolio. And it also records the record of your appraisal is essential for next year's appraisal and for the revalidation every 5 years. You need your annual appraisal. So don't lose these documents. They're very important and you should have a special file for them. Don't leave it like for the last minute and then it's your revalidation next month and then you're trying to find all your appraisal forms. Keep it nice and organized. Okay, next slide. I think the next slide is just a summary. Oh, it's a summary of your continuous professional development points. So there's 4 types of points, categories, A, B, C, and D. Okay, the type of continuous professional development activity that you're doing is categorized into 4, A, B, C, and D. A is internal events within your hospital, audit meetings, MDT meetings, e-learning that you do, mandatory training that you do. B is external, going to conferences, for example, the Royal College of Ophthalmology Congress or the meetings that you have in Pakistan. I was really excited when I attended a meeting in Pakistan with Ijaz. Sheikh was there as well in Peshawar, and that was in February, just before lockdown happened. So these conferences, that for me, that was external CPD points because I spoke there as well. North of England Ophthalmological Society is one of the biggest regional ophthalmological societies in the UK. And there's other ones like the Oxford Ophthalmological Society, which is very prestigious, and the Yorkshire Retina Society, for example. So attending these meetings will give you these points. Now, there is self-CPD, where work that you've done by yourself. For example, reading journals, often there will be articles that have CME points attached to them. Writing exam questions can give you CPD points. The American Academy of Ophthalmology website, when you become an international member, they have quizzes and they come with CPD points. So this can be your self category. And then D is anything to do with management and leadership, non-clinical essential work. For example, doing your good clinical practice course that you need to contribute to research, doing any equality diversity training, conflict resolution training, interview skills training, e-learning. So this is all category D, okay? You need to have 50 per year. Okay, can we have the next slide, which is a summary? I hope everybody's okay because we've really gone over time. In summary, your entry to the UK and the NHS, you will need to have your CV and your portfolio ready so that you can fill in your application form with good details. That will help you secure your job. Once you are in your job, you will need to have an appraisal every year. For appraisal to be successful, you must do a personal development plan. The personal development plan must be based on the 180 learning outcomes of the Royal College of Ophthalmology curriculum. I say must be, let me rephrase that. In order to have a personal development plan that will help you as a training ophthalmologist build your portfolio to a high quality, and if you have one eye on the future of doing the CSER pathway to become accredited as a consultant, then base it on the curriculum and show evidence for these learning outcomes. Thank you so much for your attention. That's the end of my talk. I'm happy to take questions.
Thank you, Adnan, and especially to my sister Rehna Khan. She is a force. She's so motivated. She will just do the things instead of thinking what to do next. And this is what we have been trying to do as British Pakistani Ophthalmic Society. We are about 220 members now. Most of them have come from Pakistan. Others are who were born here, they go to training. Some of them are still in the training, and quite a few are consultants like Rehna is. And we have a mixture of experience. But the aim is to develop ophthalmology in Pakistan. We developed a system of webinars 2 years ago. And if you look at bpos.org.uk, you'll find out that the first one we did was about ophthalmology training in Pakistan. I initially came in 1990 for my final first year's exam, passed it, stayed here for 4 years, then went back, stayed in Pakistan for 7 years, but somehow I landed up in UK again. I want to go back, couldn't for family reasons, but I go back every year, sometimes twice a year. Reason is we have suffered. There was no guidance. Nobody was telling us what to do. Now, alhamdulillah, we have our seniors, our colleagues who have been like what we call training program directors. They are education supervisors. They know how to deal with each and every situation. And everybody is willing to support. Even today, I got a message from a medical student. I wanted to join. What shall I do? I said, okay, just attend the webinar if you have time. Maybe it was just 3 o'clock when she sent me this message. Like there are other colleagues on this forum today, Fahim, he was in touch with us with regard to his audit and publications, and we got him through. And he's in training here for the next 2 years. So he will take the things back. What we have been trying to tell people is, it is not brain drain. It is about the brain drain, how you can improve the things. This has been my motto, just to develop clinical audits. And this is what I have talked about 7-8 times over the last 2 years in Pakistan. Just think positively. Don't shy away. Be truthful, because this is all about what Islam tells us, and this is what the medical ethics is. So if we can do all these things, life becomes easier. Because at night, when we go to bed, we want to have a good night's sleep, not thinking, okay, what we have done wrong, what we could. If you have done something wrong, just admit it and try to avoid it next time. So I hope with all the information you have received today, it could be spread to other colleagues. I know there were about 60 people who wanted to join, but somehow they may have other things to do. Maybe some are in practice still as a junior doctors, and others may have thought, okay, it is again Dr. Sheikh, he will be boring us with his talks and things like that. But if they had listened to Rehna, they would have really appreciated the very precise and concise and clear message. If you want to get training, even in Pakistan, just do it to a standard, because it hurts us that, okay, we see the trainees coming from India, they're coming from Bangladesh, coming from Malaysia. They're so well trained. They just fit into the system because they know how the things work. They're receptive. They're willing to listen. And I'm sure this thing will take us further. Okay. And finally, about the CSERs, clinical equivalence of surgical requirement. I came back in 2001. Obviously, I was a consultant in Pakistan, wanted to be back. It took me 7-8 years to get back to the ladder because I had no direction. And now we have trainees who come in, they get it done within 3-4 years because they know how to do the portfolio. They're linked to it. And what we are doing is making peer-to-peer friendship. Okay. Tell us you have this problem. We'll ask on our forum who is willing to help this guy. And this partnership develops. And we are having a lot of friends cross border as well, making things easier. Because life has become difficult. Medicine has progressed so much that it is not easy to grasp everything. I can give my own example. This appraisal this year, I was so busy. It was hectic. It was maybe 1.5 years. Then my son's marriage, there were functions ongoing, and then my appraisal was delayed. First time in 20 years, I had to request, please give me more time. I haven't been able to do my audit. I need to complete it. And it was very important I do it. And what I've done now is I have prepared half of it for the next year as well. So I'm online. So just don't shy away. Anything, okay, I can do it. And you can do it. I'm getting to medical college, it's not easy. Becoming an ophthalmologist is very prestigious. It's so satisfying. I hope we'll continue to guide. We'll get the guide, support from our colleagues, and anybody who is willing to come over for the training, you know where to contact us. It's just info@bpos.org.uk. Just send us a message and we'll respond as soon as we can. And locally, people are aware, consultants are aware, because some of them are my colleagues, some are junior, some are senior. And then it is like a snowball. People know, okay, there's somebody, if you go to UK, there's somebody to support you. And inshallah, we'll continue to do the same effort. Like Rehna, I mean, she's in America at the moment and she was very keen to support it. Okay, and we hope we'll continue with the same effort and zeal. And inshallah, look forward to more of these. Thank you very much.
Thank you. So we'll see you next week, inshallah, for part 2, which is contributing to a positive workplace culture and communication so that we're avoiding patient complaints.